Hello and welcome to this channel. My name is Victoria and today we will talk about postpartum or puerperal hemorrhage, the different causes, treatments and complications, as well as the diagnosis and therapy. So let's get started. What is postpartum hemorrhage? So postpartum means after giving birth. More specifically, the time just after giving birth up to 12 weeks after giving birth. And hemorrhage means bleeding. For bleeding to be considered a postpartum hemorrhage, it has to be a blood loss of equal or more than 1000 milliliters or 1 liter that occurs within the postpartum period. Alternatively, it can also be defined as a blood loss leading to symptoms of hypovolemia in the same time period. Later on, we will recap the symptoms and signs of hypovolemia. As the time frame of postpartum period is relatively large, we can subdivide it into early postpartum hemorrhage, which means that it occurs in the 24 hours after giving birth, and a late postpartum hemorrhage, which occurs up to 12 weeks after delivery. Keep in mind here that it is in the great majority of cases occurring in the early phase of the postpartum period. Now, as we know what a postpartum hemorrhage is, let's talk about the different causes. I have a mnemonic for the causes, which is as simple as 4 T's. The T's stand for tone, trauma, tissue, and thrombin. Now I would like to go through the 4 T's, one after each other, to be able to say a little bit more to each of them and fill the mnemonic with the most important information that we should try to keep in mind. So the first T stands for tone, and that should remind us of an atonic uterus, which is the reason for around 70% of postpartum hemorrhage cases. In this case, the uterus does not contract properly after childbirth, so it stays dilated and the blood vessels of the uterus will not be compressed and essentially squeezed on to close them off, and that leads to a major blood loss, as until birth, the uterus with the containing placenta was the organ to provide the developing baby with blood and nutrients. So it is a highly vascularized structure. As the placenta detaches, a desertellar large wound is left behind in the wall of the uterus, that, in the case of a uterine atony, bleeds and bleeds and bleeds unless it's taken care of quickly. Risk factors for the development of an atonic uterus is the overexpansion of the uterus during pregnancy, caused by a pregnancy carrying several babies, polyhydramnios, so the excess accumulation of amniotic fluid, the administration of anesthetics, or an infection, as for example a chorioamnionitis. The next T stands for trauma. Those can be in the form of a laceration to the uterus, or essentially any other organ that is part of or in the vicinity of the birth canal, as the cervix, the vagina, the perineum, or the anus. Also, hematomas and ruptures are possible. Trauma accounts for around 20% of all cases of postpartum hemorrhage. Also, a birth via caesarean section can be seen as a trauma, which in case of improper closing off of the surgical field can lead to a massive hemorrhage. The next T stands for tissue. Here I mean retained tissue, more specifically placental tissue, that should have been removed from the uterus in the afterbirth or the third stage of labor. This retained tissue can prevent proper healing of the uterus and it can become infected. Retained placental tissue can lead to a longer duration of the initially normal postpartum bleeding, or it can lead to excessive bleeding that starts days to weeks after the delivery. Sometimes retained placental tissue can form a so-called placental polyp. This is when the retained placental tissue becomes surrounded and basically encapsulated by coagulated blood, making it look grossly like a polyp. Its surgical removal is usually necessary. The last T stands for thrombin. This means coagulopathies that lead to an abnormal bleeding within or after the pregnancy. This is the rarest cause of postpartum hemorrhage, accounting for around 1% of all cases. This possible cause is especially important to keep in mind in women with a family history of coagulation disorders or a woman with a personal history of menorrhagia. Now let's talk about the clinical manifestation. The most apparent and acutely discovered symptom is the bleeding from the uterus. Here it is important to do a thorough examination of the patient to locate the source of bleeding properly. In many cases, the cervix can be visualized as being at least partially opened, even though it should be closed. The patient may also feel contractions of the uterus, which can be triggered by retained parts of the placenta that are attempted to be removed by the uterus. In some cases, the retained placental tissue can be found in the lower pole of the uterus and can so sometimes be seen via a speculum examination. The patient may also present with signs and symptoms of anemia or even hypovolemic shock. Symptoms of anemia include fatigue, so being overly tired, weakness, and pallor, so paler than usual appearing skin. Symptoms of hypovolemic shock include a cool, clammy skin, tachypnea and tachycardia, so fast breathing and heart rate, as well as nausea and a bluish appearing skin tone. The possible complications depend on the amount of blood being lost and the cause of the hemorrhage. Complications can range from anemia and endometritis caused by retained tissue over hypovolemic shock and sepsis to death. The diagnosis of postpartum hemorrhage is usually done by the medical history of the patient, together with a physical examination and close observation of the patient. The blood loss can be estimated by the number of pads that are being filled completely or being soaked with blood, or by weighing the pads, as 1 milliliter of blood weighs around 1 gram. Also factors as the heart rate, blood pressure, hematocrit, and levels of clotting factors in the blood can be of help to establish the diagnosis. Here we also have to keep in mind to examine the vulva, vagina, cervix, and the perineum closely, as a laceration in these organs might have been overlooked after birth, which might be the cause for the hemorrhage, in which the treatment would differ from uterine bleeding. In the next point, I would like to talk about the treatment. The treatment depends on the origin of the hemorrhage and its extent. Initially, uterotonics can be used to help the uterus to contract. However, these medications do not provide a sufficient long-term treatment, but rather an initial reduction of the blood loss until the cause of the bleeding is found and treated. Examples for uterotonics include oxytocin and prostaglandins. Also, a manual massage of the uterus done by the treating doctor can help to stimulate the contractions of the uterus. In case the treating doctor finds retained placental tissue in the uterine cavity, the retained tissue has to be removed by the use of instruments to prevent the development of an infection. Another option to stop the bleeding is by the use of a bag-free balloon or a Foley catheter. These devices are inserted into the uterus via the vagina and are then inflated by the use of water to compress the bleeding vessels of the uterus from the inside to reduce the bleeding. If the bag-free balloon or Foley catheter is insufficient, a compression suture can be made by a surgeon to increase the pressure on the blood vessels, especially in the lower segment of the uterus, and stop the bleeding from there. Also, a rupture of the uterus has to be repaired surgically. To correct the hypoxia, we can provide the patient with high-flow oxygen, or in some cases, if needed, the patient can be intubated. To correct the hypotension and shock, we can administer vasopressors that will elevate the critically low blood pressure, such as noradrenaline or dopamine. To compensate for the blood loss, it's possible to administer up to 2 liters of 0.9% sodium chloride solution intravenously. If this amount of fluid is insufficient, a blood transfusion should be done next. To correct the anemia and coagulopathy, we can transfuse blood or blood products as platelets or red blood cells. As a last resort treatment, in some cases a hysterectomy has to be considered when a control of the bleeding is not achievable or the already lost blood amount is critical to life. That's it for this video. Thank you for watching, and if you like our channel, please subscribe. Thank you very much.